with Dr. Gerard Gianoli is an introduction to post-traumatic dizziness and disequilibrium. And this is presented by the Neurotrauma Evidence Synthesis Training Group. And let's go ahead and move one slide forward, Dr. Gianoli, if you could. Perfect. So the NEST project, or Neurotrauma Evidence Synthesis Training, is a traumatic brain injury focused mentored evidence synthesis training program where we're currently mentoring a cohort of trainees to conduct evidence synthesis projects from inception to publication. And these include systematic reviews, meta-analyses, scoping reviews, and umbrella reviews. And the NEST project is supported by the National Center for Complementary and Integrative Health of the National Institutes of Health under award number, and you can read that, U24, et cetera, through the RAND Reach Center. The content is solely the responsibility of the authors and does not necessarily represent the official views of the National Institutes of Health. And then a brief disclaimer. This presentation is for educational purposes only and should not be used as a basis for assessment, diagnosis, or treatment of a health problem, medical condition, or disease. Those seeking personal medical advice should consult with a licensed physician or other qualified healthcare provider. All the images and the content in this presentation are exclusively utilized for teaching, educational purposes in accordance with fair use. And please, no contents of this presentation should be reproduced without the written permission of the author, which is Dr. Gianoli. So I'd like to briefly introduce Dr. Gerard Gianoli. He is a specialist in neurootology and skull-base surgery. He completed his medical doctorate in 1986 from Tulane University School of Medicine. He went on to complete his fellowship in neurotology and skull-base surgery at the Michigan Ear Institute in 1995. He was formerly a full-time associate professor at Tulane Medical School until 2000, after which time he went into private practice. He is currently a clinical associate professor in the departments of otolaryngology and pediatrics at Tulane University School of Medicine. He has pioneered treatments for a condition we're going to talk about today called superior semicircular canal dehiscence, as well as other vestibular disorders. He's the editor of the definitive textbook on third mobile window syndrome of the inner ear, superior semicircular canal dehiscence, and associated disorders, which is a fantastic textbook for students that are studying neurootology. He has over 80 peer-reviewed publications and has presented his research at more than 160 scientific meetings while serving on multiple editorial boards. And he was also the primary investigator for a NASA study that led to non-invasive intracranial pressure assessment to be used in the International Space Station. And he's currently in private practice at the Ear and Balance Institute in Covington, Louisiana. And without further ado, I'd like to extend a warm welcome to Dr. Gerard Gianoli. Welcome, Dr. Gianoli.
Thank you, Dr. Batson. I thank you for this opportunity to share with you something I'm passionate about, which is the inner ear. And I titled this lecture, Post-Concussion Dizziness, Don't Forget the Ear. And again, as you mentioned, we're splitting it up into two parts, but I say don't forget the ear because it seems like my colleagues always forget the ear. So this is a reminder to everyone. I have a list of kind of take-home messages I want you guys to take away from this, and I'm going to list them here. As I understand, there's a variety of understanding levels here. So some of this may be a little above your head. Some may seem kind of very simplified. I apologize for that. But throughout the lecture, if y'all have any questions, please interrupt me and ask me right away. I have no problems with that. The first take-home message is when the brain is concussed, the inner ear is concussed, almost always. And I'll explain that in a little bit of detail in a minute. The second is these injuries are well described in the literature and their existence is not controversial. The problem really is that I'm in an orphan specialty that nobody pays attention to. Third is the inner ear damage can be objectively measured and quantified. And this is something that has gotten better over the recent years. And again, one of the reasons why it's been kind of ignored is because not many places do evaluation of inner ear function. Objective identification requires appropriate testing. And that's a whole nother issue because with the advent of CPT codes and insurance reimbursement, it's basically gotten to the point where most doctors don't do vestibular testing because it pays so poorly and the tests are so expensive to the point where nobody wants to do it, and especially the big hospital systems. Fifth, the inner ear damage is treatable as opposed to what a lot of people may think out there. There's a lot you can do for the inner ear, non-medical treatment, medical treatment, and surgical treatment. And six, inner ear damage is frequently missed or misdiagnosed, and I'll go through why that's the case as well. Well, first, we're going to focus on specifically vestibular disorders after concussion, so post-concussion dizziness. And this is the ICD-10 criteria for concussion. And you need to have 3 of the following symptoms to make the diagnosis of concussion. And as you can see, we've got headache, dizziness, fatigue, irritability, insomnia, concentration problems, memory difficulty, and then intolerance of stress, emotion, and alcohol. Well, headache is by far and away the most common, but right second to it is dizziness. And 80% of TBI patients will have complaints of dizziness. Does that mean that the other 20% don't have some vestibular problems? Actually, the answer is no to that. There's a thing called vestibular agnosia, which the neurologists are a lot more familiar with the agnosia problems, but it's basically these folks have a vestibular problem and don't realize this. You don't see this as much with concussion patients, but with more the moderate and severe TBI patients, it's extremely common. These folks will have vestibular problems and have no recognition that their balance is poor. Before we get much further, I want to talk about 2 terms. The first is vertigo and the second is dizziness. Vertigo is a very specific medical term, and it means the hallucination of motion. The most classic that everybody thinks about is the sensation of spinning motion, but it doesn't have to be spinning. It can be rocking. It can be feeling like you're pushed or feeling like you're going backwards. Any sort of hallucination of motion is enough to qualify for the condition called vertigo. Dizziness, on the other hand, is I don't know what that means. It is a non-medical term. It is vague. And when patients come in and tell me they're dizzy, my first question is, what exactly do you mean? And I have them kind of characterize exactly without using the word dizzy. And it's tough for a lot of patients, especially if they've had a concussion. They may not have the verbiage to be able to explain what they're talking about. But the other important thing, I think, more important than the description of their dizziness or vertigo, is what triggers their vertigo or dizziness. And that's a very important part of the history. And we'll get into that in our second lecture. So just to kind of go over again the pathophysiology of a concussion, you've got, the head impact with both compressive forces and tensile forces as the brain kind of shifts back and forth in the skull. And you also get these rotational forces or shearing forces. So imagine you got this pressure wave going through the head. As that happens, you can get this disruption between the gray matter and the white matter, which causes this diffuse axonal injury that you've heard so much about. And then you get the subsequent biochemical changes, the perfusion changes, energy demands, utilization of the injury site, and inflammation and edema. The same mechanical forces are transmitted to the inner ear. But I would submit to you the inner ear is more susceptible to these concussive pressure waves than the brain is. And let me give you an example that is a little more relevant. I pulled this video off the internet. This is Dr. Farhad Limonati. I apologize. I don't know how to pronounce it. I don't know the fellow, but I thought he was removing a surgical tumor. Excuse me, removing a tumor from the motor cortex here, and he's using very delicate, precise technique to get this tumor out. This is, I think, fabulous technique on Dr. Limonati's part. But I will tell you, if he used this much force on the inner ear, the patient would be deaf and dizzy. And so these amount of forces that he's doing that's not going to traumatize the brain would completely destroy the ear. All right, next, pathophysiology. You can get these diffuse axonal injuries to other parts of the brain that are related to the auditory and vestibular function. And if they happen to the auditory cortex, you can get a condition called central auditory dysfunction or central auditory processing disorder. And what it is basically DAI of the auditory cortex. The hallmark symptom for that is someone who has normal hearing, but they say they have a hard time understanding people. And in particular, when there's background or competing noise. And there's a whole host of testing you can do to either confirm if the patient has central auditory dysfunction or not. One caveat I will mention is these are tests done by an audiologist, but not just any audiologist. You need an audiologist who specializes in this. And there's just not many audiologists that do specialize in this. My office is exclusively an ear office, if you would. My audiologist does not do central auditory testing. Actually, I send out for it. It's probably only a couple % of audiologists that will do the testing for this. Second is central vestibular dysfunction, and this refers to cerebellum, brainstem connections from the vestibular system. And that's a lot of what you've heard about and what everybody's focusing on. And for this, we're talking about patients with saccadic abnormalities, pursuit abnormalities, OPK dysfunction, that sort of stuff. I'm not going to talk about these today. I'm going to talk about the peripheral vestibular system. All right, and just a recap on the anatomy of the ear. I know everybody's been through this, but just to reinforce, the inner ear has got 5 sensors for balance that are connected to the cochlea, which is the hearing organ. You've got the 3 semicircular canals, and in the ampulated end of each of those semicircular canals is the sensor. Now, these sensors are only stimulated by rotational movements of the head, like rotating your head no or yes. They are not stimulated by gravity or linear acceleration. For those, the utricle and the saccule are the ones that are our gravity sensors. They also detect linear acceleration. But these are ones that we have the least ability to test and the ones that are most vulnerable to injury with a concussion. A little bit more about inner ear anatomy. I want you to focus on the cochlear aqueduct and the endolymphatic duct. The cochlear aqueduct is actually, and if you remember, the inner ear has 2 different spaces. It's got the perilymphatic space and the endolymphatic space. The endolymphatic space has endolymph, the perilymphatic space has perilymph. Well, perilymph is basically just cerebrospinal fluid. It comes through the cochlear aqueduct and gives the perilymph to the inner ear. So when you get these concussive waves, you can get a concussive wave that goes through the cochlear aqueduct. And how big or how patent someone's cochlear aqueduct varies dramatically by age and by individual. The other opening, the endolymphatic duct, which ends in the endolymphatic sac, is of course part of the endolymphatic space. And the endolymphatic duct or sac is located in a duplication of the dura. So again, pressure waves can come through that area and cause damage to the inner ear. It's most notable in a condition called large vestibular aqueduct syndrome, where patients' aqueduct is very large and the pressures get transmitted. And it's well known that these patients, if they get even just a minor head injury, they go deaf, or they'll see their hearing drop dramatically. There's other patients who have other anomalous connections to the inner ear, such as Dr. Batson referred to earlier, superior canal dehiscence. And those patients are especially susceptible to damage to their inner ear with head trauma. All right, so hopefully I've convinced you that when the brain's concussed, the inner ear is concussed. The next, we're going to talk about a little bit of the literature on injuries to the inner ear from concussions. And as I said, this is not anything new. There are new things on it, but it's actually old and it's not controversial. The very first report came in 1871 during the Franco-Prussian War. Samuel Moose reported a Prussian soldier who had a glancing injury from a gunshot wound to the side of his mastoid, and he lost hearing. So shortly thereafter, the fella dies, and he does a postmortem examination of the ear. And what he found was the bone around the ear was intact, so there was no temporal bone fracture. But what he found was there was hemorrhage inside of the inner ear. So that led to the thought that, oh, inner ear concussions, or what we call labyrinthine concussions, are probably due to hemorrhage. Well, the further on we got, we realized that and this is a cochlea showing hemorrhage inside the cochlea at different spots. But what we found was the areas of hemorrhage didn't necessarily correlate to the areas that had damage. And this particular theory kind of fell out of favor. The next one that kind of came into favor was the cochlear vestibular nerve traction injury, in that the brain is shifting and you're getting pulling on the cochlear vestibular nerve that's causing peripheral injury. That is probably not true for the vast majority of cases. I have seen cases of cochlear vestibular nerve injury, but my experience has been they're very rare. Maybe a couple percentage of cases. Then the next one, which is the most popular and the one that's believed to be the vast majority of cases, is the traveling pressure wave through the inner ear. The traveling pressure wave theory is basically what we alluded to earlier in that anatomy, where you get this pressure wave that's going through the CSF and through the brain, and it gets to the inner ear and causes disruption of these little delicate membranes in the inner ear, causing hearing loss and vestibular problems. And more recently, there's been espoused a theory on a synaptopathy. I have a hard time saying that name, but basically at the synapse where the spiral ganglia attaches to the sensory cells, that there's some disruption there. And there seems to be some evidence that that exists for some patients. Now that's the acute phase of the injury. Of course, just like the brain, the inner ear can have chronic phases too. You can see vasomotor dysfunction, progressive inflammatory states, and secondary degenerative case changes. And in some cases, you can actually see the inner ear completely replaced by bone. And we call that labyrinthitis ossificans. And it's something you can see on a CAT scan, a really good CAT scan now, which a lot of people don't think about. But if someone has a head trauma and then they get slowly progressive hearing loss in that ear, that's one of the potential etiologies for that hearing loss. So in 2018, the group from Harvard looked at their huge temporal bone library, and they pulled out patients who had head injuries without temporal bone fractures, and they excluded all of the patients that had any kind of ear-related pathology. And so they examined their temporal bones, and what they found in these 6 patients, and these are ones that didn't necessarily have a history of hearing loss, where they just had a history of head trauma. They had moderate to severe degeneration of the spiral ganglion cells, which are the innervating cells for the inner ear, or the cochlea, that is. Hair cell loss in several cases, and cochlear hydrops in half of the cases. For those of you not familiar, hydrops, or endolymphatic hydrops, is the histopathologic change we see with Meniere's disease. And that has been recognized for many, many years, that post-concussion patients can develop a syndrome that looks just like Meniere's disease. And here is histopathologic evidence demonstrating that they do get high drops of the inner ear. So in 1951, a guy named Harold Shuknick, who is one of the big giants of the field of otology at the time, did an experiment on concussion and hearing loss that will probably be never repeated, but it's one of our landmark studies, I think. And what he did in Shuknick's study, he took a bunch of cats, and don't ask me how he did this, but he trained the cats to do hearing tests. And then he took a metal bar and whacked them over the head and basically gave them head trauma. And then he had them repeat the hearing test. And then sometime later, various times afterwards, he harvested their temporal bones and did temporal bone histology on them. So what did he find? Most of the cats had hearing loss after the head blows. None had, hearing loss. This hearing loss occurred without skull fractures. So these cats did not get skull fractures. There was some recovery of the hearing loss within 2 to 3 weeks. And that's something we often see in the syndrome called labyrinthine concussion. The patient will have a hearing loss, tinnitus, dizziness, and then over the following several weeks or months, you'll see either complete resolution or some recovery of the hearing and tinnitus and dizziness. The hearing loss that he found was very much like acoustic trauma or noise-induced hearing loss. It was centered between 3 and 8 kilohertz was where the most severe losses. And if you look at factory workers that have been exposed to noise for 30 and 40 years, this is where they have their hearing loss. So the injury from getting hit in the head can look exactly like noise-induced hearing loss. But there are also others that had other frequencies affected as well. It was more variable than what we would see with noise-induced hearing loss. Then the histologic abnormalities increased with time, and everything they found was consistent and concurred with the traveling wave theory that I spoke about earlier. Same group from Harvard a year later published a study looking at temporal bones after head trauma, and they went to their massive temporal bone histology library and pulled out 8 temporal bones of patients who had head trauma and no evidence of any vestibular or otologic disease. And they had very similar findings that they found with the cochlea, except this part looking at the vestibular end of the inner ear. They found moderate to severe degeneration of the membranous labyrinth, mild to severe otolithic macula degeneration in 25%, vestibular hydrops in 25%, blockage of the endolymphatic duct in 1 case. Now, the most common thing we see after head trauma that causes dizziness is BPPV, but because of the decalcification process, that could not be assessed in this particular study. So that's the histology of it. What do we see with testing? Now, there was a paper, and this paper is probably 10 years plus old, but it looked at a combination of studies that were done on post-concussion patients and what were the effects you would find. BPPV in 17 to 50% of patients. Okay, now keep in mind, this can only happen when there is injury to the inner ear and specifically to the utricle. The utricle is the source for those calcium carbonate crystals that causes BPPV. I would argue that this is probably an underestimate. A lot of that depends on how soon you evaluate these folks and how aggressively you look for it. 50 to 84% have measurable inner ear damage by the techniques they used. 6 to 12% had central dysfunction. Now, this was at 6 months. Initially, it was higher. It was like 60%. So a lot of the stuff they saw that was central dysfunction tended to go away over time. But there was a percentage that persisted beyond the early months. Now, one thing to keep in mind in these early studies, these were all mostly horizontal canal testing. They did not test the superior semicircular canal. They didn't test the posterior semicircular canal, and they did not test the otolithic organs. And again, as I mentioned, the otolithic organs are the ones most vulnerable to damage, and those are the ones that wind up contributing to BPPV. So if you look just as BPPV as a proxy, anytime you got BPPV, you've gotten utricular damage. And we're starting to have ways to show and demonstrate the utricular damage. All right, next, inner ear damage can be objectively measured and quantified. And for this, I just want to start by just kind of going over the reflexes of the inner ear, which I think most people are familiar with vestibular ocular reflex, but the other one's less so. And there's 4 different reflexes: the vestibular colic reflex, the vestibular spinal reflex, the vestibular ocular reflex, and the vestibular autonomic reflex. And in there, there's many subdivisions of that. And then lastly, I'm just going to talk a little bit about cortical projections and input to the vestibular system. All right, so the first one, the vestibular colic reflex. This is the purpose is to coordinate the neck and head position. When you get a severe damage to one inner ear, they have and especially in lower animals like a cat, they get the head tilt reaction, as we were showing you here with this cat. And that's because of muscle spasms in the neck pulling the head over to that side. Now, we do see this in patients occasionally. For example, if I did a surgery on a patient who's got really good vestibular function, and for whatever reason I have to destroy their function, like removing an acoustic neuroma or doing a labyrinthectomy, you can see a subtle tilt of their head post-op day 1 or 2. It often corrects itself quickly. Most patients don't have a head tilt though. But what they'll complain is, they'll complain of headaches right in the back of the skull where the neck muscles attach. And it's because of those muscle spasms. Those muscle spasms will respond to massage, dry needling, chiropractic manipulation. Anything you can think of that will help a muscle spasm generally helps this symptom. But the source is this continued reflex response from the inner ear. Second reflex is the vestibular spinal reflex. And this is from the inner ear going down to all of your postural muscles. And literally from your eyes all the way down to your toes, you've got a reflex. And the purpose for that, of course, is to coordinate the head and body movement. In patients that have, or should I say, in animals that have lost vestibular function on one side, they will walk around in circles. As a matter of fact, I have good friends of mine, husband and wife, that are both veterinarians. And when I first told them what I do for a living, that I take care of patients with inner ear problems, they told me, oh yeah, we diagnose that in animals over the phone. And I'm like, really? And how do you do that? And they said, well, the phone call goes something like this. Miss Jones calls, says, oh, Dr. So-and-so, my dog is acting crazy. And so what is he doing? Oh, he's running around in circles. Oh, he's got an inner ear problem. Bring him in. And now, that said, you don't see that in people. People will correct their line of gait, but they'll constantly feel like they're off to one side. You can get unsteadiness, tremors. And then when you get a big surge in the vestibular spinal reflex, you can get drop attacks. Just a quick primer on drop attacks: when someone just suddenly falls for no apparent reason, you got to think about 3 potential sources. You got to think of the brain, the ear, and the heart, or the vascular system. With the brain, you got to think about some sort of seizure disorder, that kind of thing. With the heart and the vascular system, you got to think of arrhythmias and sudden loss of blood pressure for whatever reason. But with the heart and the brain, you almost always lose consciousness. when it's due to the inner ear, you almost never lose consciousness. So when someone's having drop attacks, the first question I ask them is, did you lose consciousness? And if they did not lose consciousness, I'm very suspicious it's coming from their inner ear. And there's a specific term for that. It's called the otolithic crisis of Tumarkin. It was originally described in patients with severe Meniere's disease. All right, so I want to show you what happens. I mentioned that people, when they've lost vestibular function on one side, they don't walk in circles. But if you put goggles on them or have them close their eyes and march in place, they will. And this is actually an old video, a tech that used to work for me who had a little left-sided injury. And so I had her do, this is called the Fukuda stepping test. And the directions are, okay, walk in place with your eyes closed, and we'll do that for 30 seconds. So here's what she looks like when she's walking in place. And what you'll notice
keep
is
the knees high, keep walking.
She'll keep slowly turning to that left side. And the cutoff that I use is 45 degrees in 30 seconds. And so she's getting pretty close to that already. So right there, she makes the criteria, in my opinion. Now, if you get somebody who's real acute, as soon as they start walking, they will start turning. And you have some that if they're very, very acute, they're just going to fall to their left side. Now, I also included this. We see this. I told her, okay, this time I want you to pretend like you're involved in a lawsuit and you want to fake. Let me back up for a second. When she did this over here, she thought she was walking in place and not moving. So this time I told her, okay, now pretend like you're in a lawsuit and you want to fake that you have some dizziness problems. And she did for me what I thought was the classic non-physiologic response that we see in malingerers. And so what they're bouncing back and forth, and they almost fall, but they don't fall. And this to me is a pretty typical, and it's not consistent to one side. That's a pretty typical, and they don't fall, because they won't fall. All right. Next, and the first one was someone who had loss of function. Now I'm going to show you someone who's getting abnormal otolith stimulation. And I'm going to show this to y'all twice. Watch this lady walk, and you see her head kind of going back and forth. And imagine if she was walking on a boat and it's rocking in the seas. If you notice, she touches the counter. She doesn't really need it to support her, but it gives her another point in space to let her know where she is. And this is a lady who is getting abnormal pressure to her inner ear. And every time her heart beats, she's getting the otoliths pushed back and forth, to where in her mind, she feels like gravity is going back and forth, and she's not quite sure where it is. And just let you look at that again. And she had been like this for 3 years and saw a bunch of doctors, and they thought, there's nothing wrong with you because your caloric test is normal. And they actually sent her to a psychiatrist. And the psychiatrist looked at her and said, there's nothing wrong with you. And the psychiatrist referred her to me because he thought she had inner ear problems. So what I did was I put her on acetazolamide to lower intracranial pressure. And after 6 weeks, this is what she looked like here.
About 6 weeks of medical therapy. And we did a repositioning as well.
Now, keep in mind, this is after 3 years of being like how she was on the left.
Now, show me how you can stand on one leg and close your eyes. Oh my goodness.
Eyes closed.
I can't do that. Awesome.
So that's just by lowering her intracranial pressure, we got that. And she, just to let you know, she had no litigation pending. She was a non-legal patient. All right, so next we're going to talk about vestibular ocular reflex. The purpose is to coordinate your eye movements with your head movements. And when it's abnormally stimulated, you can get a variety of different things. You can get nystagmus, which is the physical correlate to vertigo. You can get double vision if the eyes are not aligned right, as well as blurred vision, which is more common. As a matter of fact, one of my favorite things to hear from patients after I've done vestibular surgery on them is they'll tell me, "Doc, did you do something in my eyes? Because my vision is so much clearer now." And when they tell me that, and I never talk to them about vision, but when they tell me that, I know the surgery was a success. So one of the ways we can examine the vestibular ocular reflex is with infrared video goggles. And basically, this is in my exam room. I've got a pair of these in every one of my exam rooms, and they're just diver's goggles that will block out light. And inside the goggles is a video camera with 4 infrared light sources. So we can project their eye on the video monitor behind it. And this is my daughter who's going to demonstrate a normal horizontal vestibular ocular reflex. Now you've got vertical and torsional, et cetera, but this is the horizontal. So I'm going to have her turn around and watch what her eye does when we have her turn. So that's a normal nystagmus that happens every time you move your head. Again, this is normal, but notice when she stops, the nystagmus stops. So that's normal. The other, and that's stimulating the horizontal canal. So let's talk about the utricle, one of the otoliths that contributes to the ocular extraocular movement. When you when you're sitting upright, your eyes are aligned. When you tilt your head to the left, or excuse me, the right here, the utricle is going to note gravity is going to pull those otoconia, and it's going to note that your head's turned to the side. The response to the eyes is not nystagmus. What you see is an ocular counterroll. The eyes will torque back in the opposite direction. The one eye will come up, the other eye will come down. And the whole idea is you're trying to maintain stable or stable vision with your head turned to the side. You tilt your head to the other side, the same thing happens. Now, if you get a utricular injury, your eyes are going to rotate and one's going to come up, one's going to come down, and you'll get binocular vision dysfunction. So a lot of the times the neuro-optometrists will treat these folks with prism lenses. And there's other reasons, obviously, for binocular vision dysfunction, but one of the reasons is a utricular abnormality. Now, if you have a fixed lesion, the brain will eventually adjust to it and their vision will clear up. But if they've got a fluctuating vestibular lesion, the brain can't adjust to that and they will continue to have that binocular vision dysfunction. All right, let's talk about the vestibular autonomic reflexes, which I think get wholly ignored by everybody. So remember, the autonomic system is split up into the sympathetic and parasympathetic divisions. In the sympathetic one, that's the one we mainly see stimulated when you get an acute vestibular stimulation. And you know, of course, the purpose of the sympathetic division is it's that freeze, flight, or fight phenomenon. The symptoms, if it is inappropriate stimulated from the vestibular system, is you'll get that deer in the headlights that sometimes get mistakenly diagnosed as an absence seizure. And I can tell you, I've seen this multiple times in the vestibular lab, and I have one funny episode that occurred. I had a new tech I was training who had been working with me for maybe 6 months or so, and she did a caloric test on a patient, which induced, you know, a significant nystagmus, and the patient completely stopped responding afterwards. And she comes running to me thinking she killed the patient. And so I walk in there and I said, okay, well, let's take her pulse. Okay, she's got a heartbeat. Let's take her blood pressure. Blood pressure's fine. And within about 10 minutes, she was completely normal. And what she told us was, oh, I knew everything that was going on. I just couldn't respond to you. And I've seen that multiple times in the vestibular lab when you give a significant vestibular stimulation. And if this person would have been standing up, they probably would have fallen down. Next, it will increase the heart rate and blood pressure. And this is something that's been studied numerous times. You stimulate the vestibular system, you're going to see heart rate go up, blood pressure go up. It will also cause nausea, vomiting, and diaphoresis. You know, the sweating and the nausea and vomiting, that's probably the one that is most commonly recognized that people associate with vertigo spells. And then lastly, you can get an adrenaline dump. The adrenal glands will dump out adrenaline and you'll get anxiety and even panic attacks. And I will tell you, this is something that my colleagues never ask about anxiety and panic because they don't want to know about it, but I do. And probably at least a third of my patients have significant anxiety and panic associated with their vestibular disorder. Now let's talk a little bit about the parasympathetic division. Well, if you get inadequate stimulation, especially from the otolithic organs, you can get reduction in heartbeat. And there are some folks that are diagnosed with POTS that actually have otolithic dysfunction. It's been long recognized that patients who have vestibular lesions will have trouble with orthostasis. If you look at the three main sensors for blood pressure control going from supine to upright, you've got the filling pressure in the heart, you've got the baroreceptors in the carotid artery, and you've got the otolithic organs, okay? The ones that tell you where is gravity, right? So one of the things that kind of points to the otoliths as a significant source for POTS is that the reflex from the inner ear happens much more quickly than the reflex from the carotid or from the heart. And as well as I mentioned, when you see patients that have had vestibular lesions, they have trouble with orthostasis. So some of those folks have vestibular problems. The other thing, just to point out, a ton of post-concussive patients will get diagnosed with POTS. And it's this, well, why do they have POTS? It's this vague, well, they've got autonomic dysfunction, probably from injuring their brain, rather than thinking about the ear. And part of it I don't mean to point fingers, but part of the problem is nobody's testing otolithic function in these folks. All right, so let's talk a little bit about the anxiety and panic stuff. If you pull up the DSM-5 criteria for panic attacks, they'll give you these 13 different symptoms, and it says you need 4 of these to occur within 10 minutes to be able to diagnose a panic attack. 8 of these happen routinely with most vertigo spells. So what happens is somebody gets a vertigo spell, they go into a panic attack, they show up in the ER, and they get labeled panic attack, and they completely miss the fact that they had a vertigo spell that triggered it to begin with. At the bottom in the small print on the DSM-5, it says, must exclude direct physiologic effect of a substance, as in they're not mainlining cocaine, because you can get the same effect there, or a medical condition, such as a vertigo spell. This is not a reflex, but there are cortical projections to the postcentral gyrus that can override these vestibular reflexes. And this contributes to a lot of cognitive dysfunction we see in patients with vestibular disorders. And I'm not just talking about patients who have had concussions. I'm talking about patients who have never had a concussion. They will have cognitive problems strictly from a vestibular disorder. And probably the best way to explain this is the vestibular reflexes are some of our most primitive reflexes. They happen at the brainstem level. There is no cognitive input unless they're giving us abnormal stimulation. Then the brain has to override those reflexes, okay? So let's face it, we all have a finite amount of cognitive capacity. And if we're using up a portion of that finite cognitive capacity to override those vestibular reflexes to keep ourselves upright, we can't use them for other things like remembering your grocery list or directions to your friend's house or that sort of thing. There was a Nobel Prize winning economist by the name of David Kahneman, or Daniel Kahneman, excuse me, who wrote a book called Thinking Slow and Thinking Fast. And in that, he describes this phenomenon that I think applies in this situation. If any of you have ever tried to find someone's house in the days before GPS or without GPS, and you're driving along and you take that last turn onto the street where this person lives, and you've never been there before, and you have to now slow down to look to see the address. What is the first thing everybody does? The first thing everybody does is turn off the radio. Have you ever thought about that? But the reason we turn off the radio is to reduce the cognitive input so we can focus on finding that address. And so in patients with chronic abnormal vestibular stimulation, basically they've got a radio playing in their head that they can't turn off. Now, the good news is this is reversible with treatment. When you see patients who've had a successful treatment of their vestibular disorder, and two, have gone through central compensation, that goes away. And that has been measured in clinical studies. A colleague of mine looked at patients who had superior canal dehiscence syndrome. These are not patients with head trauma, mind you, but he did neurocognitive testing on them prior to surgery, and that 3, 6, 9, and 12 months after surgery. And what he found was 3, 6, 9, 12 months after gradually improved over their baseline pre-op levels. And that's what patients have told us for years. They told us about this brain fog, and that once their inner ear problem's fixed, the brain fog slowly lifts. There's also an interesting animal model that was produced where someone would drill open part of the inner ear. Well, they would do cognitive testing on these gerbils, drill open their inner ear, then repeat cognitive testing. And what would happen is the hole caused a vestibular problem, but it was reversible because the hole would slowly close up. Once it closed up, their cognitive function improved back to baseline. So that is something that is a positive for these folks. And particularly what I see with these folks, the shorthand is short-term memory problems, difficulty focusing and concentration. So I'm going to end it here. We've covered the first three. When the brain is concussed, the inner ear is concussed. These injuries are well described in the literature, and their existence is not controversial. Inner ear damage can be objectively measured and quantified. And I'm going to cover the second half in my next lecture. So do you guys have any questions at this point?
Let's open it up now for questions and answers. People can unmute themselves who want to ask Dr. Gianoli questions. And
I
just
have several questions.
okay, go ahead.
I have a VNG that does torsion, but I underutilize it because I don't know what metrics to use, like asymmetries, degrees per second. What is clinically significant?
Yeah, one of the problems with torsional nystagmus is a lot of the programs that measure them don't do a good job with it. You know, unlike vertical and horizontal, they do generally a very good job. The torsional one is difficult. So I have to admit, I find it a little hard to rely on some of them. I do use Micromedical or whoever owns them now, Interacoustic, I guess. They have a video ocular counter roll program, which measures static positions of the eye and compares it to the baseline, which that one's helpful. And that's probably the main one. The ones where I'm looking at torsional nystagmus, I usually like to just look myself rather than rely on the VNG tracings.
Okay. On tilt tests, I have been trained looking at vestibular spinal reflex to look at a standard one versus head position changes. Have you done that, or would you agree with that approach?
I have to admit, I don't do tilt table tests.
Okay.
But if you look at the literature with head position, head up versus head down,
Right.
you will see abnormalities in patients with abnormal vestibular function. Whereas the ones that have like a lesion or loss of function, you won't see any change.
Okay. Fukuda tests I've been doing for 20 years.
So yeah, so a couple of things. I'm glad you asked about the Fukuda test. I love the Fukuda test when it works. Problem is, it can be confounded if someone's got a bad knee, a bad ankle, one leg shorter than the other, things like that. And part of the reason for using the 45 degrees rather than 30 is because you really want to make sure they're going that way. But again, if they got a bad hip, they're probably going to go that way anyway. I have not had the experience of it always going one way. My definition of normal is either stay in place or slowly move forward. So forward translation in my mind is normal. But you do occasionally get someone who will fall especially if they're an acute injury. And to be honest with you, I don't even do it on them. But I think at least in my office, the Fukuda I like, but I like when it correlates with my rotary chair test, which is a much more objective way of looking at the range of the VOR
Right.
response and the compensation pattern. Now, if someone's got a vestibular lesion and then it's been compensated for, theoretically their Fukuda should be normal. So it's for an uncompensated vestibular lesion.
Hi, yeah, I'm a medical student. I was just curious. I really enjoyed your talk. And for those of us starting out, are there any resources or recommendations, and maybe you could provide it afterwards, that you'd recommend for those of us wanting to learn more?
Absolutely, my book.
Okay.
Actually, there's a bunch of things. It's kind of stuff that you're probably not going to come across in medical school, and partly because they just, they don't talk about the ear so much. You'll get a little spattering of it in anatomy and physiology. But I can suggest, I'll look up some stuff for you and some stuff to give you a background and a fun basis for things.
Dr. Gianoli's clinical website, the Ear and Balance Center or Institute, Dr. Gianoli's
Institute.
Institute.
Yeah.
It's a good resource site as well. He's got a number of videos on there and reviews all of the physiologic testing that's done. And I'll put his website in the chat function for you, Kate, and for anyone else who wants to just reference the website. I'll also put a reference to his book on third mobile window syndrome, which is a sort of the definitive textbook. And thanks, Kate, for chiming in.
I have an hour's worth of questions, so I'm going to just book a consult with you. I see the symptoms of what you're talking about in at least 3 people directly related to me. So my questions are, how does one find a good neuro-otologist in your hometown to pursue treatment? Secondly, I've heard of the Epley maneuver that you can do at home. Can you just get everyone to just do the Epley maneuver and see if it improves their symptoms as a way of understanding their own situation? I guess those are the 2 main questions.
So you get into lecture number 2 now, but
Okay.
the short answer is vast majority of patients with vestibular problems after concussion will resolve spontaneously. It's just, that's the good news is. And that's also true for probably most patients that get an attack of vertigo or so. As a matter of fact, I tell my office staff that if someone calls and says they have vertigo, it's less than a week of symptoms, tell them that we're not available for at least a month, because chances are it's going to go away by the time they come to see me, and it's a waste of a visit. So, most vestibular problems will resolve spontaneously. I had an interesting episode a few years back in the course of, it was May. I had 5 different physician friends call me, and they were upset because they had vertigo. And so they called their friend who deals with vertigo, and they described to me what sounded like BPPV. And what I told them was, look, it sounds like BPPV. Give it a week. If it's not gone a week, come in and we'll do the Apley maneuver or what have you, and we'll make it go away. Every single one of them it resolved inside of a week. So that's kind of the more common scenario. What I see in my office are the ones it's going on for a long time. My typical patient's been dizzy for 2-3 years max. I've got some that have been 30 years, if you would. But the Apley maneuver is benign enough that it doesn't hurt to do it. But keep in mind, it's not necessarily the answer, because you got to wonder why they get those crystals loose to begin with. As far as you're looking for a neurologist in your hometown, again, that's part of the next lecture. My colleagues, although we're the specialists on vestibular disorders, don't want to take care of vertigo patients, and it's an economic issue. The good news is there's been a lot of education of physical therapists over the last 20 years on how to help patients with Apley maneuvers and vestibular rehab therapy. And a good number of folks will do well with just that simple, the therapy. So the first step I would tell you is to find a good physical therapist that does vestibular rehab therapy.
Any other questions from anybody in the group?
Yeah, I would ask a question. Richard Cerruti, physiatrist in Washington. First of all, Dr. Gianoli, that was just an outstanding lecture. I think everyone would share that opinion. I learned a lot. I felt like I was drinking from the fire hose, but it certainly stimulates further learning, I would say. I mean, as somebody who treats head injured patients, I'm often left with a few dilemmas. One is, and you've had some of my patients already, when do they need a ticket to New Orleans, where you reside? Also, just the early dizzy, blurred vision, TBI patient, they've done some basic testing. When do they go to vestibular rehab? When do they go to functional neurology? When do they go to neurooptometry? And if you have any sort of bedside pearls you can offer there, it would be helpful.
Sure. So again, that's getting into the second lecture, but
yeah, I realize that.
Maybe we hold some of these questions, but go ahead.
Okay, yeah.
At your leisure.
The short answer is the first 3 weeks, I would just have them, they talk about the concussion, the brain rest. I would add to that body rest, because one of the things you can see is if they strain, they can aggravate some of the conditions for vestibular disorder. So first 3 weeks, just take it easy. Majority of them, it's going to resolve. If it's not resolved by 3 weeks, then I think vestibular therapist is appropriate, because some of these folks are going to have persistent BPPV. Some will have a labyrinthine concussion that needs additional help getting compensation. If they're not getting better by 3 months to 6 months, up in that range, that's a bad sign. And those are the folks that are still going to be having trouble a year, 2, 3 years later. So it's that 3 to 6 month window. And the important thing being, they're not getting better. Those are the ones.
And that would pretty much reflect my practice in terms of, neck pain, headaches. I do a lot of PRP in the cervical facets. And so I would sort of say the same thing. A lot of patients come to me through a chiropractor, and I'm like, if you're getting better, go back. But that sort of 3 to 6 month mark, that's when we start to get a bit more involved with more advanced treatments. So thank you. It's excellent.
Dr. Gianoli, I want to just clarify a few terms for the group. I'm not sure that everybody understands vestibular compensation. Could you go ahead and clarify that term for the group?
All right. So when you get damage to the vestibular end organ, let's say I go in and I do a labyrinthectomy, or I go in and just completely destroy the inner ear. And we do that sometimes for patients with bad episodic vertigo. That sudden loss of function, the brain does not like. But it immediately starts to adapt to that. And that adaptation process is called central compensation. In the setting where I completely remove the function, that's a stable lesion, and that's one of the prerequisites to getting central compensation. And during that time that they're going through central compensation, they're still going to have some disequilibrium, off balance stuff. They shouldn't be getting spinning spells. And then slowly you'll see improvement for about a year. The average patient is typically, I tell them, you'll see central compensation take about a year. It's front loaded. You see most of the improvement in the first 3 months, but you'll get continued improvement for other 9 months. In the lab, I can actually see improvement for out to 3 years, but by then the improvements are so slow and subtle that the patients don't generally notice it. When you've got a fluctuating vestibular lesion, that's the majority that I wind up seeing. They're not compensating because the lesion keeps changing. And I think the easiest way to explain it to patients, it's sort of like someone who's had a stroke and they can't talk. And then slowly over the course of a year, they learn how to talk. Well, it's not because that part of the brain grew back. The brain just rewired around it to allow them to talk. Well, it's the same thing with the vestibular lesion. You don't get the vestibular function back. The brain just slowly adjusts to the lack of information on that side. But the caveat being, it's got to be stable. So my job is stabilizing the lesion. You know, I don't fix anything. I tell a patient, I just stabilize it, and then your brain adjusts to it. And there's a variety of different ways of stabilizing it.
Dr. Gianoli, can you speak briefly about decompensation, meaning once there's been central vestibular compensation, there's also the possibility of decompensation or losing that central compensation. Can you briefly speak on that?
Sure. So take again the example I just gave of someone where I've destroyed their inner ear and their episodic vertigo spells pretty much stop right away, but they're still off balance and they're going through this central compensation. And then over the course of a year, they get to the point where they're essentially asymptomatic. Well, that patient can have things that will cause the brain to forget how it adjusted. And there's 3 big categories I warn them about. The first is fatigue. And they see that especially early on. And what the patients will tell you is they'll say, Dr. Gianoli, when I get up in the morning, I feel great. But as the day goes on, my balance gets worse, worse, worse. And their brain is just getting fatigued and it wants to go back to that previous condition before they started learning compensation. Over the course of a year, that gets less and less, and it requires more and more fatigue before they get this decompensation, usually something like they never slept that night or that kind of. Second situation is some significant vestibular, some significant physical stressor, like they get a bad case of the flu or they get their gallbladder taken out or something like that. And what you'll see is after the episode of the flu, their balance is bad for several weeks. And what it is, it just overwhelms the brain. Brain wants to go back to how it was working the previous 50 years because it's lazy instead of how it's been doing the last year or so. And their balance is off for a while. Last one is severe emotional stress. And that one I tell them is the most difficult to control, but it's the same process. You get someone, your spouse dies, or you get a financial catastrophe, and you're so stressed out about it, it overwhelms the brain, and the brain wants to go back to doing things the easy way, before it learned the central compensation. And the treatment for all 3 is the same. You get over the stressor, whether it's sleep or get over the flu or get over your, whatever the stressful life event, and get back on the vestibular rehab therapy.
Dr. Gianoli, I'll add in one decompensator that you mentioned to me in one of our discussions, which is THC use. Can you speak to the use of regular use of marijuana with respect to decompensation?
Yeah, I wouldn't call that so much decompensation as much as it's probably a vestibular sedative. It's something I've had a number of patients come in with medical marijuana lately, and you guys probably wouldn't be surprised to know there's not much in the literature on it. You can get a bunch of funny eye movements. It can act as a vestibular sedative. As far as how it affects vestibular testing, no one's ever done a study, but you can kind of extrapolate. Well, if you get vestibular sedation, you're going to see reduced vestibular responses on testing. But it's something that a lot of folks get into after head injuries because it does kind of reduce that abnormal vestibular stimulation. But the problem is it will prevent central compensation. The medical marijuana, the benzodiazepines, any sort of sedative medication can delay or prevent central compensation. So one of the things that I do, the first thing the primary care doctor is going to do is, you're dizzy, here's some antivert. Well, the first thing I do is I take them off the antivert. And it's because of that prevention of that central compensation.
Okay, thank you, Dr. Gianoli. Any other questions? I know Dr. Burns is going to come in with his final question. Any other questions before we?
One question.
Dr. Wright, yeah, go ahead.
Dr. Gianoli, do you see third window syndrome and operate on that?
Yeah, I have a unique history with third window syndrome because I did my first superior canal dehiscence surgery in January of 1998 before anyone had ever published or said anything about it. And I was like excited because, hey, I discovered a new disease and I'm going to wait 6 months, see how this patient does and publish it. And then 3 months later, Lloyd Minor at Hopkins published his first 2 surgical repairs. So I have the second article about third mobile window syndrome or superior canal dehiscence. And back then it was extremely controversial. Everybody thought it was a rare disorder. And so consequently, if you had superior canal dehiscence, there were only 2 places in the world that you could go to get treated for it. It was either Hopkins or come to Louisiana by me. And so consequently, I started seeing a ton of patients from everywhere. I mean, literally, I would see them from all over the US, Canada, Latin America, Europe, Asia, etc., for superior canal dehiscence because nobody else had any experience with it. And because of that, now I'm starting to see the ones that, yeah, they had surgery and and now I'm vision stuff at this point. So I see a ton of it because of my history with it. And that's what led to the textbooks. The Springer, the medical publishing company, approached me because one of my patients is a publisher and said, we need to do a textbook on this and you need to do it. And so I've got 60 authors doing 30 chapters or so in the textbook on it. And it's just increased the number of patients that specifically come to me because of third mobile window syndrome. Now, in the setting of concussion, I really think you see the patients that have prolonged dizziness after a concussion, the ones that are 2, 3, 5 years out, still dizzy. If you just looked at that subgroup of patients, my guess is that's really high on the incidence of third mobile window syndrome. I would bet probably 90% of those folks have third mobile window syndrome. And it's because if they didn't have a defect in their ear, they would have been better already.
Yeah, and Dr. Gianoli, I would say I think about 14 cases we've sent your way in the last year, and I would say the majority of those, the vast majority, have third mobile window SCDs.
Yeah.
So just to give you a sense, Dr. Wright, because I know you're working with a chronic TBI population as well.
Yeah, and the ones Dr. Batson had sent my way were basically that. They were all dizzy anywhere from 1 to 5 years after head injury, and they weren't getting better. So they're kind of a self-selected group. If it was just BPPV, they're not going to wind up in my office. It's either going to resolve spontaneously or some therapist is going to treat it. If they just got a labyrinthine concussion, they're gradually going to get better regardless of what the doctors do. But that last group, the ones that have a fluctuating problem like third mobile window, I would add in that group, you can also see post-traumatic endolymphatic hydrops, which is sort of a induced Meniere's disease. You can see that as well. But some would argue that's just another way of saying they have an intermittent perilymph fistula.
Dr. Wright, are you?
I appreciate the whole presentation. It was wonderful.
Thank you.
Dr. Gianoli, can you clarify the presence in the context of third mobile window syndrome? Can you briefly speak about autophony?
Sure. Yeah. So if someone's got we're talking about a dehiscence, we're talking about a hole in the bone that encases the inner ear, and the prototype is superior semicircular canal dehiscence. And so what you've got is you've got the dura of the temporal lobe effacing basically the inner ear. So there's a hole, and what happens is internal pressure can get transmitted to the ear, as well as sounds can get transmitted through that defect. See, the purpose of having the inner ear encased in bone is you've got the oval window and the round window. This works better with a diagram, which I got for the next lecture, but the round window acts as a means for the sound pressure to get shunted to the cochlea and not to the vestibular end organ. In the condition autophony, which is kind of the same group as conductive hyperacusis, these patients will hear internal sounds louder than they should. And it's typically hearing their voice louder, which is autophony, pulsatile tinnitus, which they're hearing the pulsations of their brain. These folks will hear their eyes move and blink. They will hear joint movements like their shoulder and hip joints and weird, bizarre stuff like that. And it's because of that defect in the skull, and it just gets transmitted to the inner ear inappropriately.
Well, this has been a fantastic lecture. I know this could go on for a long time. It looks like we have some vestibular enthusiasts, which is great. And we'll look forward, Dr. Gianoli, to your next lecture, hopefully in November. You and I will put that together and figure out when we are going to put that in the schedule. And then I don't know how many evidence synthesis trainees there are here, but we're going to be bringing on another mentor hopefully next year. We've currently got 10 systematic reviews in process, and Dr. Gianoli and I have discussed doing a systematic review on vestibular deficits, and he, of course, would be senior author, content expert. So if there's anyone that develops a passion for this, that wants to work on the methods side, Dr. Joshua Goldenberg here today, he's the head of methods in the NEST project. I'm the head of content education. But thank you again for all attending. You're welcome to send me feedback. I know this was a fantastic lecture. We're already getting great comments in the chat section here. So if you have follow-up questions, please address them to me. I'll pass them on to Dr. Gianoli, and we'll welcome Dr. Gianoli back hopefully in about a month. And again, thank you so much, Dr. Gianoli. This has been a fantastic
Dr. Batson, feel free to share my email address with the group.
Absolutely. Thank you again. Thanks everybody.
Welcome.
Okay. Have a wonderful weekend, everybody.
Bye, guys.